Good evening, colleagues. Thank you very much for participating in this COVID-19 webinar. I would like first to thank the ISN for their always supporting the educational mission all over the world, and in particular in Africa. A special thanks for the contributors of the Afghan COVID-19 committee. These deeply thanks colleagues and contributors of the recently published Afghan COVID-19 guidelines. Their valuable inputs and recommendations were based on long experiences in the field of the kidney disease. Just to introduce some of the COVID-19 pandemic here and the nephrology, we are living in the world of uncertainty. The kidney is a major organ affected with COVID-19. Thinking on renal replacement therapy on such affected patients should be based on multifactorial issues based on our past experiences on renal replacement therapy in sepsis and other comorbidities. So we have to think about the pathophysiology of the disease of the COVID, kinetics of toxins, molecules, and mediators, physics of dialysis. For sure, randomized controlled trial are needed, but we don't have such a lecture of time. So my message is here is to giving the best options now can probably save lives. So our agenda in this talk, we have introductions, philosophy of hemodialysis choices, safety in critically ill patients, dialysis membranes characteristics that fit our requirements to manage patients with COVID-19. Patients on maintenance hemodialysis are on accumulating risk, and patients with acute kidney injury related to COVID-19 with a special emphasis on the different techniques in hemodialysis for patients with COVID-19. So let us go to the introduction. As the worldwide outbreak of coronavirus disease has demonstrated that we are all one part of a very small world where diffusion of contagious disease is inevitable. The potential mechanism of kidney involvement in patients with COVID-19 are multifactorial, profoundly interconnected, and have important implications for the extracorporeal therapy. While extracorporeal therapy have also been proposed as approach to remove cytokine, here we can see that nephrology implications is back again. So our past and the current experiences in nephrology are cornerstones now to treat critically ill patients who are in need. While patients on maintenance hemodialysis are also vulnerable for the disease. Subsequently, all of them may probably have chronic inflammatory reactions during the past years on dialysis. So augmenting this effect with cytokines will impair as well their living or their health care. Going to Africa has a long experiences on dialysis exceeding 50 years. So hemodialysis kinetics, modelings, and researches over decades of the journey of hemodialysis in Africa is well paced. So we have the manpower sufficient to do dialysis in this pandemic. So in order to understanding the techniques depends on the availability of the renal replacement therapy, and we have to understand the disease and treatment options. This is the basics of any dialysis procedure. We have to think about what do you need to remove the toxins, whatever this toxin is in the blood or cellular components, and their behavior from movement from cells to intravascular compartment. The pathophysiology of such toxin generations, its equilibrium, and as well its elimination. Or it may be protein binding, so it will be difficult to be removed. Then to have to decide the philosophy of dialysis based on the techniques as well on the physics of hemodialysis. So a lot of options here depend on your experiences and availability. You can have hemodialysis in short, intermittent hemodialysis, or prolonged procedure or continuous renal replacement therapy. All of them should have a convection-based as well diffusion-based dialysis. When you look to the physics of the dialysis, we have dialysis membranes qualifications, sieving coefficient criteria, and safety of dialysis component is an important issue as well. With COVID-19, there is organs crosstalks. We have lung affection, kidneys, gut, as well as the heart. So our question now is, does renal replacement therapy can improve all of them by removing the toxins and circulating cytokines? It's questionable. From our long-standing understanding of the sepsis-related syndrome in ICU, as well the availability of all the hemodialysis modality, we will understanding the cytokines problems on such patients and how to remove it is well not easy as well. So we have hemoperfusion or hemodialysis procedure. Nephrologist experiences in ICU sepsis for decades, so we don't need an additional resources for understanding the disease or in the techniques. We need only logistics in the manpower as well in the machines of hemodialysis and disposables. So different techniques using specific extracorporeal circuits and devices, heart, lungs, kidneys, and liver can be partially replaced or at least sustained. We can sustain at least during the severe phase of the syndrome. And this concept is called extracorporeal organ support. Based on this, we have to do convection-based therapy, are in particularly important for systemic inflammatory response syndrome. So, hemodialysis, what we must change in hemodialysis pre and post COVID-19 pandemic, and probably what was an optional should be a must in the hemodialysis journey. No place here for low flux dialysis. Convection therapies and longer duration are the major players in the affected patients. We have to remember that no one size fits for all. So the process of renal replacement therapy in this pandemic is the availability of the techniques, individualizing therapy. You need more permeable dialysis membrane. You have, in the time related, you can do intermittent hemodialysis using high flux, or online hemodiafiltration, or offline hemodiafiltration, and expanded hemodialysis, removing more middle molecules, or extended hemodialysis means longer duration or a continuous renal replacement therapy. So this is a process, depends on different possibilities. One of them is the logistics available. Additional is the patient's requirement, as well the clinical conditions in the qualifying the cytokines in the patients before going to do renal replacement therapy. Hemodialysis and COVID-19 patients need more safety adequacy approaches, because we all know that during hemodialysis may be hazardous for the patients. We can have organ stunning, thrombogenicity, hemodialysis-induced inflammation. For decades, we learned from hemodialysis that it could be a burden for the patients and could improve his general condition. On the same time, you may hurt the patients by endotoxin, impurities, bioincompatibilities of the membrane. So be ready for the increasing needs and preparedness for all your needs and resources to cope for this upcoming increasing number of patients requiring hemodialysis. When looking to the financial and reimbursement rate in the all over the world, and in particular for those with low income or middle income, like in Africa, the lower reimbursements making hemodialysis very difficult to be done easily in the low-income countries. And we need more and more resources, in particularly financial resources and higher reimbursements to cope with that. So more resources are required in Africa as well in other low and middle income countries. From the additional side, as Egypt is at the heart of the Africa, and it has a mission, we have a different cooperations with other colleagues and brothers from Africa. We have the ESNT, Egyptian Society of Nephrology Virtual Academy, accommodating more than 12,000 nephrologists from Africa. We did as well annually 6 hemodialysis courses to more than 20 African countries with collaboration of the Egyptian Foreign Affairs. All of them are in the heart of the Egypt, with discussion, training, and educational missions, with communication all the time later, and it is in English and French. And it's our mission is to spread the education to all the African countries who are in need. Coming back to the hemodialysis on regular or maintenance hemodialysis, we understand that cautions in hemodialysis sessions to avoid complications and ultrafiltration rate should be adjusted to maintain the maximum hemodynamic stability. This is in particular for the patients requiring dialysis with COVID. So if you are treating patients with COVID-19, you should think about hypercoagulations, endothelial dysfunction, organ stunning, and ischemia, and to avoid hypotension, because hypotension and organ stunning can deteriorate the general condition of the patients and make the patients worse. So if you are doing renal replacement therapy, we have to take care about the hemodynamic. It's well known that hemodialysis can induce organ stunning, and if we are doing hemodialysis for patients with acute kidney injury, the renal perfusion may be lower than usual, so delaying the recovery. So these are a concept of dialysis safety during patients with acute kidney injury or patients with COVID-19 in general. Also, we have learned that extracorporeal therapy carries the risk of thrombogenicity, and this thrombogenicity coming from the facing of the blood to the dialysis circuit, in particular the blood tubings, as well the filters. So if there is bioincompatibility reactions, we have complement activations, proteins absorption, coagulation activation. And this coagulation activation and platelets recruiting back again to the blood, catalytic on fibrin formation. So this may be very important to take care about that, because patients with COVID-19 have thrombogenicity as well and coagulation impairment. So patients with maintenance hemodialysis have hypercoagulation as well. They have endothelial dysfunction for years due to accumulation of uremic toxins. I will just mention one of them, which is arginine driven, which is the ADMA or asymmetric dimethyl arginine, which is a very potent nitric oxide inhibitor. So patients with accumulating uremic toxin during the journey of hemodialysis, during maintenance hemodialysis, have impaired nitric oxide synthase, and so have higher platelet aggregations, impaired vasodilatation, and smooth muscle cell proliferation with superoxide radicals. So this is a chronic inflammatory reactions in patients on maintenance hemodialysis, superimposed by COVID-19. When to choose the best renal replacement therapy with COVID-19 patients, do your best and what you can do and what you are expert in, looking to 3 categories, looking for the dialysis adequacy and safety. And if you're looking for the safety, you have to avoid completely intradiabetic hypotension and endotoxins transfer or other impurities. And if you are looking to the adequacy, you have to look about the time and permeability or the flux. Targets and goals is a preventive strategy for sure, and avoiding dissemination, early detection and isolation. And if you are doing dialysis, you have different techniques depending on the patient conditions. If you have a maintenance hemodialysis patient and stable acute kidney injury, you can do intermittent or SLAD. But if you have a dialysis in critically ill patients, like unstable acute kidney injury and unstable maintenance hemodialysis, you have to do prolonged intermittent renal replacement therapy, and this will be discussed later. Choice of hemodialysis membrane. My message is not all high flux membranes are equal, and those are identified by their saving coefficients and cutoff values, while albumin leak amount. What is the best to cope for the COVID-19 is to remove the cytokines. And you look here, this is a difference of permeability of the dialysis membrane from low flux, medium flux, high flux, super flux, or protein leaking membranes, medium cutoff, high cutoff, and plasma filter. And according to the molecular size cutoff, as well for the albumin loss. We are interested here for this category of dialyzers membrane to remove the cytokines. So we have superflux, or what is called high performance dialysis membrane by the Japanese classification type 5, or medium cutoff, or what's called protein leaking membrane, which is more than 3 grams, usually more than 4 grams. And the high cutoff, with a very high cutoff membranes approaching the albumin, but the albumin loss is high. So let us discuss about the medium cut-off dialysis membrane and superflux dialysis membrane, which are eventually required in the dialysis for the COVID-19. And this is the classic saving coefficient, the difference between the high flux and the medium cut-off. The gap in between is the cytokines molecular weight. And this is the schematic of the uremic toxins in patients requiring dialysis. Beyond the beta-2 microglobulin, we need at least double size of the membrane to remove, because starting from the cytokines is 17 or 18,000. So just the beta-2 microglobulin now is not important for the patients with COVID-19. We need more permeable dialysis membrane. And dialysis membrane for COVID, which is the best option, is to have a dialysis capable of removing cytokines, and increasing the time is a must in critical ill patient to balance between cytokine production and removal rate. For diameter is essentially the difference between both of them, and the medium cutoff or superflux is an intermediate between high flux, regular high flux, and high cutoff dialysis membrane. It's far away from plasma filter. The difference in technique between expanded hemodialysis or HDX or medium cutoff dialysis is removal by permeability. You cannot do that in hemodiafiltration therapy, for example. You use that as a regular hemodialysis, but removal of toxins by permeability. While in hemodiafiltration and the convection-based therapy, like online hemodiafiltration or continuous replacement therapy, removal by permeability and transmembrane pressure. So you cannot combine medium cutoff dialysis with hemodiafiltration. The FRANC guidelines look for that with a comprehensive guide to fit all the patient needs, and a multidisciplinary team who in need of nephrologists to guide their service from kidney view. All patients with CKD5D acute kidney injury, as well as CKD patients and renal transplantation, are included. This guideline is in accordance with other international guidelines in the pandemic of COVID-19. Africa, 50 years of dialysis challenges and progress. Years of starting hemodialysis in Africa with acute kidney injury as well for poisoning had started very early in 1950s, with Egypt and South Africa are the beginners, followed by Kenya, Nigeria, Cote d'Ivoire, Ghana, and Tanzania. And on maintenance hemodialysis, Egypt as well as South Africa had started through the early 1964. So dialysis prescription in chronic dialysis with COVID-19 may be various degree of cytokine ranging from mild to severe form, cytokine storm associated with raised interleukins like 6, 18, 12, interferon gamma, and dialysis modalities used will depend on the staff competencies, availability, and consumables centers should use modalities with which they are familiar. COVID-19 and dialysis, why we should be worried? Because already patients on maintenance hemodialysis are older age, malnutrition, cardiovascular disease, diabetes, lung disease, and less efficient immune system. So with the need for dialysis in the overcrowded settings where many patient nurses, physicians, and support staff are present at the same time. So hemodialysis patients are at higher risk. And the healthcare facility shortage, especially in dialysis population, if the spike of the curve, we cannot cope more with patients. So we have to try the preventive strategy to flatten the curve. So COVID-19 in dialysis patients, adding a few more pieces to the puzzle, maintenance hemodialysis might present with a wide range of symptoms, and their clinical outcomes, special mortality rates, are dramatically high, reaching up to 30% in literature. Maintenance hemodialysis patients already have chronic inflammatory reaction, malnutrition complex syndrome, and for more than 4 or 5 years, we are asking about to remove cytokines during hemodialysis, routine hemodialysis before the pandemic, because it's related to the chronic inflammatory reactions. Hemodialysis management keys in COVID-19, high flux dialysis membrane with myoglobin CV coefficient more than 0.5 is recommended for the maximum dialysis efficiency. And this is just an approach. If you have a dialysis patients stable, you can continue hemodialysis or hemodiafiltration and monitor for fluid balance and symptoms. And if you find deterioration, you can reevaluate for the dialysis prescriptions with higher doses of hemodialysis or hemodiafiltration, or more frequent dialysis is required. And if it becomes critical, more intensified hemodialysis, especially in ICU treatment with prolonged intermittent renal replacement therapy or continuous renal replacement therapy and SLAT. The differences in hemodialysis efficiencies depends largely to both the convection volume removed and duration of treatment. So using high flux, superflux, medium cut-off membranes, and using the correct surface area and correct time, you can catch the goal. Convection volume, basically, during high flux, it's just 4 to 8 liters, while low efficiency hemodiafiltrations defined by less than 15 liters in post-dilution mode, and high efficiency more than 23 liters in post-dilution mode. Is it correct time to use high-performance dialysis membrane? Yes, I agree on that. And it has an excellent biocompatibility with effective clearance of target solids. There is still little data, no randomized controlled trial in patients with COVID-19, but we have to do what we can do. And this is coming from the Task Force Lombardy, Northern Italy, with the use of the medium cut-off dialysis may be an adding value to enhance removal of middle molecule and subsequently inflammatory mediators. Acute kidney injury patients is reported with COVID-19 ranging from 20 to 40%, with an average of 25 in some literatures. And it has a many pathogenesis. We can have a hypercoagulations, where you can use anticoagulant, inflammatory cytokine or cytokine storm. We can use renal replacement therapy. You can have as well direct invasion by the virus and ICU-related nephrotoxic drugs, fluid restriction, or hemodynamic instability. So dialysis with acute kidney injury in COVID-19, depending on the availability of the modality and or trained personnel. The available modality is the continuous therapy or prolonged intermittent renal therapy or slide techniques, high flux techniques, and in some circumstances you may need peritoneal dialysis where the automated one is much preferable. Accumulating evidence suggests that delayed renal replacement therapy initiation is safe. You can use loop diuretics, potassium chelators, and if there is lack of dialysis or ICU nurse, non-dialysis or non-ICU nurses may be recruited to monitor patients undergoing renal replacement therapy. Accumulating evidence for endothelial injury with COVID-19 is responsible as a part for the post-kidney and lung injury. So dialysis modality was the safest way for the biocompatibility and avoiding impurities and other factors that may increase body response to extracorporeal circuit are selected. The key message is to use the continuous renal replacement therapy with specific adjustment for patients with COVID, possible use of cytokine removal strategies. Ideally, in patients with early signs of hyperinflammation and cytokine release syndrome. The difference between before and after COVID-19, after decades of experiences in ICU renal replacement therapy, it's exactly the same, but only think about the coagulations of the extracorporeal circuit, which is common with COVID-19. And the hypercoagulation may make the patients to lose 25 milli, 250 milli blood during the coagulation. The effect of sustained low-efficient dialysis versus continuous renal replacement therapy on renal recovery after the acute kidney injury in a systemic review meta-analysis, no different, so you can use SLID regularly. So preparedness of the kidney replacement therapy in critically ill during COVID-19, depending on many scenarios, you have plan A, plan B, plan C, D, and E. And if you have a lecture of time and flattening the curve, so you are in the plan A or plan B. But once you have more patients like plan C and plan D, you have to merge different renal replacement therapy like mixed CRRT, moving from 72 hours to just 10 to 12 hours to cope with the increasing number of patients requiring dialysis. And you can find here that this nice planning for patients requiring dialysis. And if you are in, for example, plan C, you can mix of 24-hour CRRT and shift paced, less than 12 hours per patient per day based on clinical needs. Or in plan D, where you have as well shorter dialysis duration to cope for the NAMPER, but you can use the regular dialysis machine in a SLID technique. I usually recommend that for most of patients because we have much more experiences in that as well. CRT is more complicated and needs experiences which is not fitting for many centers. So extracorporeal don't compromise experimental antibody-based therapy used in COVID-19, such as tocilizumab, immunoglobulin. Neither hemodialysis filter nor hemoadsorption cartridge remove antibodies, which is a very big 150 kilodalton, far exceeds the upper size of the molecules. Using the best membrane, porosity may be of value. And these are cytokines molecular weight on target or in the radar of dialysis to be removed, starting from interleukin 1, which is just 17, so it's bigger than even the beta-2 microglobulin by 1.5 times. And the hemodialysis convection is based on the substitution But be aware that during COVID-19 and slow dialysis, the filtration fraction should be lower than 25 because coagulation is high. So filtration fraction in the safe limits during online routine hemodiafiltration is between 25 to 30%, but during patients with COVID-19 or slower dialysis, you need a filtration fraction around 20% only. So our guidelines, depending on the availability, RRT and SLAT in ICU, you can use that preferably according to experiences. And this is the technical and the logistic consideration. ICU may need portable RO system. Hemodialysis machines should be installed with endotoxin filter to improve the water available or dialysate available for dialysis. And this is the standard SLAT techniques using a dialysate flow of around 200 to 300 ml per minute, blood flow, treatment durations from 8 to 12 hours depending on the cases, treatment delivered daily or alternative using ICU nurse, monitors, machines, have no contraindication systemic anticoagulation with unfractionated heparin to the target to purchase thromboplastin time. And when you looked at for the prolonged intermittent renal replacement therapy, you can use the same approach as well. You can use the CRRT machine, but with higher doses of effluent rates, reaching 40 to 50 ml per kg per hour, with a treatment duration from 8 to 12 hours. Notably that medium cutoff and high cutoff dialyzers should not be used in CRRT nor on hemodiafiltrations. Circuit clotting and frequent filter change may be required. So suggested prescription is to do continuous veno-venous hemodiafiltration pre and post in the regular doses of 25 to 30 ml per kg per hour. And in the presence of cytokine storm, the dose should be regularly reassessed. And CRT is beneficial for maintaining volume, hemodynamic, and allow adequate nutritional supports. It's as well improve the clearance efficiency of medium and small toxins, molecular toxin, and can maintain body temperature. CRT is particularly indicated in patients with AKI who are suspected to have high level of cytokines with hemodynamic instability. I will leave the text for the just to be for your guidance later, and it's prescribed in the text of the guidelines, as we say that we can be flexible for the doses. And there is advantage of SLAT indeed that include its use in hemodynamic unstable patient and its ability to use equipment for multiple patients, lower requirement for anticoagulation and lower cost with wider availability. While standard duration hemodialysis can be used in stable patients with high quality reverse osmosis generated water. So standard operating procedures for the SLAT performed with standard dialysis machine using high flux dialyzers, duration and frequencies between 8 and 10 hours. Looking for the QP, QD, it's between 150 and QD with 300 maximum. Ultrafiltration is about 300 ml per hour. You need portable RO. Start with the smaller dialyzers and then upgrade accordingly to avoid excess clotting. And this dose is equivalent of KT over V around 1 to 1.5, urea reduction ratio around 65%. And you can use glucose-containing dialysate and to avoid hypoglycemia and attention for potassium level monitoring. Considering the vascular axis, if the patient develops indication to start renal replacement therapy, it is like the same. You prefer the right internal jugular vein, double lumen catheter, and this is especially recommended for the patients as well who are proning or on ventilators. The anticoagulation schedule, if the patient is on systemic anticoagulation, you may need no more anticoagulants, but regional citrate could be used, taking care about the liver. If affected, it will be contraindicated. You can use systemic heparinization and treatment without using anticoagulants. Discarding everything after the dialysis, all disposables, and do dialysis equipment disinfections according to the routine work. And this is a good recommended further reading, giving the indications, preparation, prescription, delivery, as well as the monitoring of the patient with acute kidney injury who required to do dialysis. And I think it's very enriched to read about, because it's covering all the process of renal replacement therapy in such field. Finally, still questionable the plasmapheresis risk and benefits. It will be published soon, is in this article to highlight that plasmapheresis, although it's an unproven strategy, could be useful approach by the mechanism of alleviating the cytokine storm and decreasing the viral load. I'm not with plasmapheresis, because you will remove as well antibodies and you will remove beneficial. So plasmapheresis should be decided in cautions and in very occasional cases. In particular, some randomly recorded Guillain-Barré syndrome with SARS-CoV-19 infection, but its coincidence or as a cause is still not identified. Thank you very much, and I hope that I could cover the talk, and please stay safe and welcoming all other questions. Thank you very much.